Well, good morning. Welcome to those who joined already. I'm Paul. I'm going to be chairing the conversation this morning. I'm just going to wait a few more minutes. We've got a few people joined already. We'll just wait for a few more people to join, and then we'll get things underway. We've got a fantastic panel. I'm really looking forward to a conversation this morning on the subject of personalisation in health and social care. I hope you are too.
I realise we're remiss, Paul. We should have some background music going whilst people are entering.
I won't offer to sing or play an instrument. I don't think anyone would thank me for that.
Karaoke.
Hopefully all the attendees are sitting comfortably. You've got drinks, and one nice thing about doing the online webinar is no need to do housekeeping about fire alarms and so forth. Trust in the platform will stay stable. Teams has been pretty reliable for us lately. A moment more before we start formally, but I think we've got a fantastic panel. We've got a good spread of people from across different sectors. So hopefully this will be a really interesting conversation. And for those who are wondering, yes, we are recording. This will be available afterwards for people to watch back and listen to our sage words and discussion. And perhaps those who aren't able to join will be able to catch up. I think helpful to know that there'll be a Q&A section at the end, so you can feel free to put questions into the chat or any comments that you'd like to make. We've got a colleague who's staying off camera, who's monitoring that, helping out in that role. So thank you very much, Claire. And I think 2 minutes past, let's get started. So once again, welcome. I'm Paul Bradley. My background is as a consultant psychiatrist. I work with adults with learning disability in Hertfordshire. I'm the Chief Clinical Information Officer for the Trust, so lead lots of digital programs in the organisation for the last 10, 12 years. And for the Royal College of Psychiatrists, I'm the lead for informatics. So I'm interested in this agenda from a variety of angles, and really pleased to be able to welcome a great panel to discuss this topic this morning. So I'm just going to go around in order and ask people to introduce themselves. So Jo Johnson first.
Hi, I am Jo Johnson. I'm Assistant Director for Safeguard and Assurance within our Adult Social Care team at North Lincolnshire Council. My background's predominantly been within the care sector, something I'm really passionate about, and something that's always been important to me is making a difference, making a positive difference to people's lives, and anything that we can do to continually progress that is something that I'm very interested in.
Fantastic. Jo Spearing.
Hiya, I'm Jo. I'm a research fellow at the Centre for Health Economics at the University of York. By training and my day job, I'm a health economist. And so at least a large chunk of what I do is research how the design of policy affects outcomes. So that's what my interest in personalisation is.
Fantastic. And Lorenzo.
Thanks, Paul. Hi, everybody. Lorenzo Gordon, co-founder and director at Maldaba, software development agency and solution provider for the public sector, based in London. We've been around since 2002. And my real interest is, from a technical and digital perspective, how these tools that we create and we innovate can really support people to best manage their lives and get the best outcomes for themselves in terms of their health and well-being, and improving their conditions, whatever they may be, in the ways that work best for them.
Fantastic. So just to reiterate, we're recording the webinar this morning, as hopefully you'll all have seen, be able to see that back later. Please do put comments and questions in the chat, and we'll pick them up as either as we go along, or most likely we'll have a Q&A section at the end. And we're going to have a roundtable for about probably 40 minutes or so, first of all, where we'll go through a few topics under the heading of personalisation in health and care. I think starting off, let's just have a bit of discussion about what we mean by personalisation. Maybe sort of opening a few statements on that. So, Joe, from a social care perspective, what would you understand by personalisation?
For me, personalisation is about putting the person in the centre, seeing the person as a human, as a person, not often you hear a patient or a service user. It's about a good life, everybody having a good life, and getting the support and having choice and control over that support as and when they need it. We all go through different experiences in our lives, but often we experience that different power shift in control in those conversations. And actually, the person who should be in control of their own life is that individual. They know themselves more. I think there's something about that knowledge power as well. So giving people the tools to be able to make fully informed decisions and then having that available choice for me. So for me, it's about putting that person in the middle.
Yeah, fantastic. I think we're already getting raising important things about power and choice. Capacity might come in there as well. And Joe Spearing, you notice, just to challenge the chair, we've got two Joes. So
Yeah.
forgive me for being formal and using his surnames, but Joe Spearing.
Yeah, so I when I was first invited to do this panel, I did what academics do. I went to the library and got out some books on personalization. It turns out people have written like not just like one book, but books defining what personalization is. From my perspective, I think of personalization just as a set of policies that all have in common one of two things: so either increasing autonomy or control for the user of the service, or making the provision of services more sensitive to the preferences of that user. And that more or less covers, that's quite a loose definition, but I think you have to be that broad to encompass all the things that people mean when they say personalization.
Yeah, I think that's what we're going to get into. That it is a really broad term, and there are a lot of ways to interpret it. And thank you for reading some of the books on it to save us, and hopefully summarizing a lot of that learning. How long has that research been going on for, Joe? How far back did you find things?
So it's a good question. So the term personalization first emerges in a Demos report in 2004. And it was kind of a retrospective rationalization of why personal budgets and direct payments, which started in the 1980s and sort of got formalized in the 90s, why those had been seen as so successful. And so this report in 2004 was looking back at those personal health budgets that have been paid primarily to people with chronic physical disabilities and saying, the reason why these were so well received and why practitioners and recipients were such a fan of them was because they were speaking to this idea that the end user was ultimately an expert in their own condition, that they wanted more control over the way that service was provided, and that also if you made the provision of service more sensitive to what they wanted, it could be more effective. And sort of from that point on, it sort of got picked up by policymakers and politicians who were interested in applying those principles sort of more broadly. And so one spanner to throw in the works like really early on is just to note that this notion of personalization is a kind of ex post rationalization of a very specific set of policies in a very specific context. And so what I think we should always be wary of is making sure that we're not taking principles that we really like and applying them in contexts that are completely different and expecting to get the same result. So one of the things that I tend to be very skeptical of as an empirical policy analyst is the idea of overgeneralizing results from a very specific policy context. I think it's very likely that personal health budgets, generally speaking, seem I mean, the weight of evidence seems to be that personal health budgets are quite cost effective at improving health related quality of life, but it doesn't necessarily follow that that would also apply in all areas of health and social care. That's a kind of an open question as far as I'm concerned.
Yeah, and I think we're going to go on and talk a lot more about the progress and the pitfalls in personalisation. Lorenzo, I'm going to bring you in. So from a technologist point of view, or from your broader experience, how do you understand personalisation?
Well, I didn't go to the library. I knew Joe would, so I outsourced that task to him. I think, and some of what I'm about to say has already been touched on by both of the Joes. For me, personalisation is very much about control. It is about the ability of the individual to have an active participation in both the planning and execution of their health and care, because that's empowering, and because the evidence does tend to suggest that you get better outcomes. But I think taking a slightly broader lens of it as well, as the NHS necessarily moves from the original model of a kind of factory-based system of getting people who are ill in, treating them, getting them better, and then getting them back into productive workforce, and moves into a much more complex scenario. And I talk about the NHS, but the impacts really are being felt in social care, because you're talking about people living outside hospital for long periods of time with chronic multiple conditions, what we call comorbidities, that the only way that the system, the health and social care system, can support all of that is if people are better at looking after themselves and are supported to do so. And that's why personalisation is so critical, not just from an individual's point of view, but from the system perspective.
Fantastic. And I think I'm here not just to chair, but also to contribute, so I'll make sure I do so from a clinical perspective, so as a psychiatrist, but maybe taking a slightly broader view across Western society at least. I could say if we go far enough back, then healthcare was almost by default personalised. Everything was done on an individual basis. And probably the 20th century saw us try to streamline and industrialize healthcare to a greater extent. We saw the growth in clinical care of evidence-based medicine, pathways of care, and probably even before that, we started to see sort of institutional development. So my field is the care of adults with learning disability. If we go maybe 200 years back, then most people were living in their communities, in society. But if we go 100 years back, or 60 years back, say, then people were living generally in fairly institutional care. There was a very literal one-size-fits-all model that was being perpetuated for some time, where because of the scale of need, I think standards slipped, and that was part of what we're now probably trying to recover from, where large institutions would try to put people into the same sort of setting, treat them in the same sort of way, and hope for a positive outcome from it. Peppering it with anecdotes from my colleagues recently retiring, talking about their early careers in, for example, learning disability nursing in the institutions. The one size fits all was so literal it might have been applied to the clothing that was provided to people, and it's tragic to hear about, frankly. It's great that we've moved to a position where things are being personalised on every level, and it's not just the care that's provided, but really people's lives. People can express their dreams and ambitions, their hopes and desires, and we work as a care system together to try to find ways to meet those and develop people's abilities and skills. Also go on, because I think the other side of it is in increasingly precise healthcare as well. So I think one of the ones I want to bring in is around care for conditions where you can now, using things like genetic testing, get much more specific about how you target and treat conditions. Well, so where do we think we are so far with this sort of agenda of moving from, one size fits all, I think, if or standardized care into something more like personalized care? And Joe Johnson, do you want to say a little bit more about where you think things are at the moment?
Yeah, first off, just reflecting on, just made some notes, I guess some of the comments we've made already. And I thought it was really that people being the experts in their own condition. And I was just thinking, really, where we are is people are living much longer with health and social care conditions. However, the support we provide are often short-term interventions, often strangers who might be really great at their job, but that's a small-term intervention or a discussion. But actually, the person at the centre is going to continue to live and manage that health and social care condition, and that's why it's really important that they're seen as the expert, and that we develop those relationships. In terms of where we are now, from a social care perspective, it is about understanding well-being, the social factors, not just somebody's condition, but actually what is important to an individual, which may be different to what we see. But that is, I would say, whilst embedded in social care practice, one of the things we need to do, though, is ensure that we've got time, that we create the time to really understand somebody, to really understand what's important to them. And when I was thinking about examples before this, there was a comment somebody once made, and it stuck with me, actually. We asked people about their experience of safeguarding and what was important to them, and we asked them to write down on a card and show that card. And one of the people said, "This is your job, but it's my life." And that is something that's always kind of really sort of hit my heart, and
Yeah.
I guess always try to draw forward and everything that we do, really.
I think it's a fantastic quote, and it's a fantastic point, and it's so easy, or it can be easy to be distanced and detached from, how much the decisions that we make, whether they be policy and economic decisions, whether they be technology and design decisions, or whether they be health and care decisions, do affect people 24/7, for years and years of their life to come, and the relationships and the ripples as well. So not just that one person who you might be making a decision about in some cases, but then all the people who are involved in their lives as well. Joe Spearing, what do you want to give a perspective on how things are now?
Well, I think so. I think it's important to think about the notion of personalisation as being something of a spectrum, where on the one end you have no decision-making capacity for the patient or the end user, and then on the other hand you have, complete autonomy. I think if you go on to the NHS's personalisation plan, they're quite keen to say that personalisation's always been an aspect of the NHS. So they'll say that even in 1948 you were able to choose your GP, which GP you signed up with. In the mid 2000s, you got to choose who was going to do your elective surgery and that kind of thing. So it does seem like the movement is towards more choice and control for patients. So we're already at the point where I think the majority of people who are eligible for personal health budgets, and that's really kind of the poster child for personalisation within the policy space, are getting personal health budgets. Where I think my sense is that those have thrown up a lot of complicated wrinkles that need to be worked through. It turns out that when you start to personalize care, you realize why you didn't do it before, which is that you've now introduced a hell of a lot of dilemmas that you have to work through. And I also think that at the heart of healthcare, you have this problem of the relationship between the patient and the doctor, where the doctor is often rightly positioned as the expert, but that makes it very difficult for the patient to express preferences. And so we've had all these campaigns in the NHS. I think in the mid 2010s, you had No Decision About Me Without Me, and things like that, which have been trying to lean heavily on this idea that it shouldn't be just the doctor that's making decisions. But that's a tension that we have to live with, because the reality is that as much as we say, and I agree with Joe, I think this is a nice thing to talk about, that the patient is an expert in their condition. That is more true in some cases than others, and there's always going to be a tension where the doctor is providing some expertise, and that's just a tension we're going to have to live with, right? But I certainly think that the trend seems to be towards great levels of personalisation in health and social care. But I now think that we're bumping up against dilemmas and problems that we kind of have to feel our way through.
Yeah, absolutely, Joe. I mean, I could bring in things about the Mental Capacity Act and shared decision making. I might talk about that in a minute, but I want to get perspective from Lorenzo and perhaps where you think we are, and maybe where you've seen things go particularly well.
Well, actually, just listening to both Joe Johnson and Joe Spearing, it actually makes me think a lot about shared decision making. Paul, Maldaba have done a huge amount of work in shared decision making. Many years ago, we developed a product called Analisa, which is all around multi-criteria decision analysis, which is just a technical way of talking about if you have to make a choice of multiple decisions. So, for example, let's say you get diagnosed with something, maybe cancer, and you have a number of treatment options. Those are your choices you have to choose from, and then there are a number of factors to consider when you're making that choice. So it may be things like, what's the prognosis of each of the treatment options? What's the impact on your quality of life? What might be the impact on your family and your relationships? And Analisa was really about trying to synthesize all of that information. And I guess I kind of agree and disagree with some of what's been said when we talk about expertise and that tension between clinical expertise and lived experience. And one of the things that Analisa was really helpful in my thinking, but also when we deployed it in terms of research around cancer treatments, which we did working with various clinicians, is to separate the technical clinical expertise of people who work either in social care or work in the NHS. If we continue with the cancer example, people who understand, well, what are the statistics? What's the likelihood of doing nothing versus taking this chemotherapy? What are the likely impacts on your quantity and your quality of life? And for that, you need professionals. You need medical and social care experts in order to look at that from a statistical point of view. But there is another expertise. There is the expertise of lived experience of all of that data doesn't say anything about what my life is going to be like if I take those medications or if I don't take those medications. And you may have two people who are presenting with the same diagnosis and are given the same range of options, but the impacts may be wildly different because their lifestyles and their backgrounds and their family and friend relationships are very different. And one of the things I was really proud about with Analisa is that it allowed that marrying of the two. So there were areas where you could put in your clinical evidence and say, this is what the likelihood outcome is. But there was another part of the program that allowed you to say how much that mattered to you as an individual. So let's say, Paul, both you and I get diagnosed with the same condition and we're presented with the same range of options. I may say, well, actually, these parts of my life around the ability to continue living independently are far more important, whereas you may say, no, what's really important is that I stay alive for as long as possible in order to support my children. And that means we may have different outcomes. And one of the things that was really interesting about that is that we've deployed this many times in different situations. So in terms of contraceptive decision making, we've worked in terms of learning disabilities. We've worked in a range of areas that without fail, patients get this straight away. They always understand it and they're more than capable of managing it. The people that we really have to support to change their attitudes and their behaviour are the professional staff. And I'll pause there because others will want to speak, but I think there's a lot to unpick about why that is the case and what we as a community need to do to support that change.
I think you're absolutely right. I think it's culture probably within health and care is slower to change than the sort of knowledge base and what really works well. And part of professional training, of course, is to build some expertise, to build some deep knowledge of a subject. And that guides what we're able to offer and what we're able to offer as being a sensible option or a practical option. But of course, the challenge then is to, as you say, marry up what's important for that person. The shared decision-making model is I think, being very widely talked about now as being quite an effective way to address that. And I don't think it's anything new in its concept, in as much as probably at medical school 25, 30 years ago, we were talking about that you would sit down, you would talk about what was important to somebody. You wouldn't barrel in with this is the answer, this is what you're going to do, and this is when it's going to happen. And I'm not sure how far back you'd have to go for that to genuinely have been the case. Not to say that it isn't on occasion even now. I think there's probably some times when we're under such pressure to deliver care and deliver it at volume and pace that sometimes the right and important considerations can be seen as a nicety rather than as a necessity. So I do think that we're in a tricky, tense position because, as you say, Joe, we can't personalize everything for everyone all the time. We'd be tied in knots and never be able to take a step forward. I think we've got to have some capacity to do things according to a little bit of standardization and guidance. Yeah, fantastic. I think we've probably all agreed that aiming towards some level of personalization is important, and thinking about how practically to address it is maybe the next step. Lorenzo, you've already given us a great example in one way. I don't know, Joe Johnson, do you want to talk a bit more about the practical implementation?
Well, I think, as we've mentioned, it's a culture shift as well, isn't it? But I guess we need to look at the environments which we work. Sometimes it's quite easy to slip into that paternalistic kind of approach of, wanting the best for somebody, and actually not really then fully understand what is important to that person. And often when you speak to them, just as you've said, Lorenzo, if you ask, different things in terms of well-being will be important to different people, but often it's living in their own home with their families and people that love them within their communities, or having a job, feeling valued. And I know it's maybe not the best example, but I found myself doing something with a family member, actually, who it was my grandma who wanted to clean her carpet. So she mentioned to me, I need to clean that carpet. So I went away and borrowed a carpet cleaner and told the family, and went round to her house, and she was really mad because she says, no, I wanted to clean my carpet. I didn't ask you. And she wanted to do it, and she's done a little bit at a time, but I just saw myself checking myself that I actually just wanted the best for her. I didn't want her to do it because I didn't want her to fall, but actually I'd taken away that control. And so it's so quite easy to slip into that. I guess one of the things I think as well is quite important is, and I think it's when you speak to people with lived experience that you realise how your practice and how our practice within social care can impact on people. So for me, it's always important to listen to and gain feedback constantly from people with lived experience, and understand how people would best prefer to be communicated with, but also to help shape our practice. So often we will do, when we're auditing our practice, we look at three things. What does our data tell us in terms of what's happening? What does our practice wisdom tell us? But actually, how did that feel for that person? So we always speak to people, because it might, you might think, oh, well, it looks like it's gone okay because we're counting the numbers. But the most important part is, what was the outcome from the individual? And that sometimes might mean them wanting to take decisions that we might feel is risky, but that's okay because it's their informed risk. So one of the things I think we do, or we're starting to do well, is involve that citizen's voice as the expert in the development and the design of our services, but also the testing, and then continually improving based on that feedback. But also involving people more in terms of our day-to-day, I guess, interviews, about how we work, because it's people that are the heart of everything that we do. I'm not just sure if I'm answering the question here. I'm going off on
I think the conversation goes where it goes. I think there's so many trails and tracks to take on this. You made me think of co-production, which of course is a theme that's maybe a step removed from personalisation, but it's about making sure, maybe as part of that there are opportunities for personalisation in a pathway of care. I mean, I was going to come back, Joe Johnson, on the budgetary challenges. Social healthcare is struggling, but social care is under even more pressure. And so I wonder how you marry up those two challenges. You've got to do more with less and make it a good experience for people.
Yeah, it is a pressure. I guess there's an argument that if you are taking a personalised approach, you should be supporting people in the best way and giving them informed choices, which actually in the longer term should help you become more financially sustainable. Yes, I think it means that we've got to really look at what we do and how we do it and how we do things in the best way. Making every contact count, but also the systems in which we're working with. So if we look at the care sector, which is quite traditional, and it's difficult when you're trying to meet outcomes for individual, but you've got a staff workforce which you have to deploy for a care sector, and meet so many people's needs. It's really easy to see how things slip back to that time and task model. And I think sometimes it's coming back to how we organise, how we pay, how we commission for services that enable these services to deliver on those outcomes. So traditionally, if we pay for time and task, we will get a time and task response. Whereas if we start to think about block payment or the terms and conditions for those workers, actually we might get so much more and support people so much more than just that short amount of time that we're there. The other thing is, I guess, the difficulty of not only the reducing sort of resource in terms of finances, but is demographic pressures of an aging population as well alongside that. And a workforce. And I think that's where we've really got to think about. I know when I speak to people, we often think about those regulated care activities, but if you speak to somebody, they'll often say, they won't say I want home care. They will want to meet an outcome, and it's about how we can develop those relationships more. It's as part of that conversation, taking that strengths-based approach and looking at our community assets. How accessible are they? What is the barriers to people potentially accessing these services that we need to then reconsider and design, even as a more of a preventative approach? So while somebody might have a health and social care need here, there's the whole of themselves, and how do we ensure that everything that we do is accessible?
Fantastic. Well, Joe Spearing, I'll bring you on the same sort of topic, but we've managed to get more than halfway through without mentioning the other dreaded P that's in the headlines at the moment: productivity. So productivity and personalisation, are they in attention?
I don't think they certainly don't have to be. I mean, one of the findings from the Vanguard programs that looked at the personal health budget pilots was that they were quite cost effective in terms of raising health related quality of life per pound spent. So that seems like that can be there seems to be no tension in productivity there. More generally, if you look at NHS productivity, it has tanked in the last few years. I mean, we're back down to like late 1990s levels of productivity in the NHS. That we're kind of hoping is a short run effect of what happens when you expand the NHS workforce more or less entirely in the acute hospital sector and not in the areas where which we know are more productive right at the moment. So this is a roundabout way of saying I think the most likely sources of poor NHS productivity at the moment are the fact that social care budgets have been squeezed for a good 15 years. And we know, some colleagues of mine have done this research. We know that a pound spent on social care generates greater reductions in mortality than a pound spent on hospital care. And then also you have this bizarre situation where nobody can get a GP appointment, but also I think it's around 10 to 15% of newly qualified GPs are unemployed. So the money's not going into primary care, which again we know is relatively productive compared to acute hospital-based care. Coincidentally, social care and primary care are the places where you have the greatest scope for implementing these personalisation changes, right? Particularly the idea of helping people to manage their own chronic conditions. That's something that goes through well primary care or social care, but a lot of the time I'm thinking about things like historically policymakers have spent a lot of time and money trying to help people manage type 2 diabetes better, or even diagnosing it in the first place, right? There's around 1 million people in the UK who have type 2 diabetes who don't know it. So a lot of that money that the NHS is going to need in order to improve its productivity is going to have to go into reaching out to people in the community and making sure they have the resources that they need to figure out their own the management of their own chronic conditions, right? And one of the big policy problems in the NHS is all the money's been going to fighting fires. The only other thing I'll say about productivity and personalisation is that one of the concerns I have about personalisation is that I worry that politicians are going to hear personalisation as an opportunity to save money, and there's a very big difference between saying we're cutting budgets in real terms. Why don't you help us personalize how we're going to reduce services for you? And social care and primary care, and empowering you to live a more independent life. Why don't you help us figure out what we need to spend that money on? Right? Those are two ways you can do personalization. And I think it's very important if you're going to talk about long run NHS productivity, that you're talking about the second one and not the first one. Because if this is just being used as a kind of smokescreen for implementing more cuts to social care and primary care, then this is actually going to be adverse for long run productivity, I think.
Absolutely. I think, Lorenzo, I'll come to you with a similar question. I don't know if you want to build in something about the personalization, prevention agenda. I think Joe Johnson mentioned briefly there as well. All the technical ways that we can help to address some of these issues.
Yeah, I was just mulling it over in my mind as I was listening to Joe Johnson and Joe Spearing speak, and I think, you know, we've been on the ground doing this sort of work for longer than I care to remember, and we've done it in times like now where there are exceedingly stretched budgets, and we've done it at other times where there has been more money in the system. And I think it's undoubtedly true that right now money is not being spent in the right places, and I completely agree that, you know, for personalisation of care, where money needs to be spent and where it is not being spent is in both primary and social care. That's where the funding needs to go. And what we see as the impact of that is that without that, people have neither the time nor the headspace. There simply isn't the resource to think about doing things differently, because it's all they can do to get through the day. And I completely understand that. And until we address those basic things, nothing's going to change. But that will change at some point, because these things are cyclical. I've seen it different before, and I will see it different again. The other point, which is true even when there is money, is how you change people's framework of thinking about themselves as employees and professionals, change their jobs, change their attitudes and approaches to supporting people. And this is true regardless of money, but you can't get to these points in the conversations if you haven't got the resources, where people understandably define themselves through their roles and their jobs. And I think, you know, as Joe Johnson has touched on, I completely agree, there is, with the best will in the world, quite a paternalistic sort of implicit approach to this, that I'm the expert and I know what's best for you. And it's that thing of, when you're caring for someone, what you want to do is the most risk averse thing, whereas the person who is being cared for wants to do the thing that they enjoy their life the most. And it's talked a lot about in terms of how you care for the elderly, for example, towards end of life, where we want them to be safe, but they want to be happy. Otherwise, is it a life worth living, sort of thing? And so when I said before, so the barriers we encounter often are with professionals, this is part of what I was alluding to, about saying, well, we need to support people to think about things differently. And that's where personalisation is more than just a buzzword. It's more than lip service. It's actually a real thing to say, if you are a carer, say you're a social carer and you're going in to support people in their homes, yes, you know about things like hygiene and cleanliness and nutrition, absolutely, and you can support with that. But what actually matters to that person? Is it that they can do their own shopping? Is it that they can do their own cooking? Is it, as in the case of Joe Johnson's grandma, that they can scrub their own carpet? Those are the things you need to support them with, and you need to change the framework, as Joe was saying. You know, if you pay for time and task, that's what you'll get. So you need to set different goals and different sanctions that reward that. And I don't think that is, I think it's a false tension to say that's going to impact on productivity. I think if we're looking at it this way, then the fault is on us that we're looking at it in the wrong way, because this isn't about productivity. This is about supporting people as best possible and supporting them to look after themselves as best possible, to either improve any conditions they have or to maximize the health that they've got for as long as possible, so that we're focusing on the quality of their lives. And, you know, from a technical point of view, as the digital people, that's where things like, for example, Hear Me Now, our digital health passport for people with a learning disability, that is specifically around allowing people to express their preferences and wishes to what matters to them using multimedia, so that they can articulate it. And we've seen some wonderful stories about people who are in supported living, for example, who are non-verbal, who got very physically violent because they couldn't say what it was they wanted to do day in, day out. And yet what they did was they recorded in Hear Me Now the things that they liked doing, And then every day the support worker would say, okay, well, here's your list of things you like doing. And then they could choose which one they wanted to do today. Was it watching TV? Was it going to play football? Was it going to the park or going to a cafe? And what they noticed, and this is where it's really interesting, is that the violent episodes decreased to almost be non-existent. And if you want to talk about productivity, then the amount of support that person needed, because it didn't need multiple people to restrain them, suddenly were realised. Now, that wasn't born out of a desire to be productive. That was born out of a desire to support someone and listen to them in the best way possible. And that's why I say I think it's a false dichotomy.
I think that's a great example, Lorenzo. And I think it's really important for people to think differently maybe about it. I think, as you say, introduce it provocatively, productivity, as we must have more appointments, we must see more people more quickly, or we must do something at scale, rather than in a way that's thinking about that person as an individual. I mean, we touched on a couple of really interesting ideas, and maybe the thing that was coming to my mind was curiosity, that you need to approach all of these things with curiosity and openness to. Maybe the other one is difference and diversity. So, the other demographic change, as well as our aging population, is an increasingly diverse population. I think what you could sort of assume might be correct, or probably shouldn't have anyway, but what might have been assumed as correct for a monoculture years ago, you definitely can't assume anymore. And so we need to embrace that range of interests and needs and desires for people.
If I could just
go on,
one quick point. You talked about measuring productivity as appointments per pound spent and stuff like that. Economists have forever been saying, for the love of God, do not measure productivity like that in healthcare. It's difficult exactly how else you replace it, but in our research we tend to measure it in terms of, as far as possible, in terms of health outcomes, health related quality of life, quality adjusted life years, things like that, for exactly all the reasons that we're discussing. Is that drop and give me another 5 appointments is not actually necessarily an effective way of measuring if you're doing your job well.
No, and worse still if it's literally counting them rather than even considering what's been done of any benefit to anyone. Claire's reminds us of another couple of questions that we were discussing. I can see Ian's going to come in with a comment shortly, but health inequalities maybe is a topic for us to touch on briefly. Jo Johnson, health inequalities.
Yeah, health inequalities. So just reminds me of something. I recently went to a presentation that was done by our Director of Public Health, and the way they showed it I thought was really impactful. So they showed a bus journey, and at each stop in different places within North Lincolnshire there was the healthy life expectancy age. And I think it really visually made you see that where you live would have quite a stark difference on what would be your anticipated healthy life expectancy. Which for me, some of them just being across the road, and the differences of that, and really understanding that. So that's some of the work that we've started to really look at, what some of the drivers. So I've got something down here about like housing, economic activity, different qualifications, social mobility, how people's time spent, like that best start in life and education, and how all of these can impact, I guess, on that healthy life expectancy, and what we need to then do to try and improve some of these inequalities, really based on those factors, which I think is the other thing. I said the other day when we was having a catch up, I think we've got lots of data, but what we don't really have sometimes is the intelligence, or we don't use it to its best effect to be able to really start to consider how we are going to do things differently to improve inequalities and healthy life expectancy.
Absolutely. Ian's bringing in the chat here the Tony Blair Institute Digital Health Record proposal, And I think that links, doesn't it, to the About Me information. So to be here with you, I'm missing the Professional Record Standards Body AGM, and it was the PRSB that launched the About Me standard a few years ago now, which is bringing together what's important for the person. And NHS England have really mandated that we incorporate that into our records more explicitly, so that we do balance up what's critical for a person. The tricky thing is if it's locked away in our EPR and our electronic patient record within the silo that some of our organisations hold, that's considerably less useful than if it's shared, and even better if it's actually contributed to and written or authored in some way by people themselves. And Lorenzo, you've already described how people can do that with one platform. Any thoughts on the Tony Blair Institute's recommendation, Lorenzo? Do you want to come in on that?
Yeah, well, I smiled a little bit when I saw that, and thanks, Ian, for adding it. We actually helped the PRSB co-produce that About Me standard, and I was delighted. We were one of the first to actually launch an application to incorporate it. So the PRSB About Me standard is in Hear Me Now, and one of the phrases, and it's in that paper that Ian linked to, and I hear it a lot in my job, is a single source of truth. We have Pathways to Care, for example, our digital discharge system, which is deliberately designed to be a single source of truth. So it spans the clinical EPR on the one hand and the adult social care systems on the other, where historically they've not spoken. The reason I smiled is there are so many siloed repositories of this single source of truth, which makes it a paradox, right? What we wanted to do when we created the About Me information is we wanted to link in with the NHS spine, because actually, and I completely agree with Ian's follow-up point about it being in application neutral formats, because what we wanted to do is put it into the reasonable adjustments flag within the NHS. That's the right place for it to sit. That says, if you know nothing else, if you've never met me, these are the things you need to know in how to treat me when I turn up on your doorstep in an emergency situation, or the sorts of rooms where I'm comfortable being and where I'm not comfortable being. Just the basic stuff on how to support me and how to communicate with me. And that wasn't possible, not for any technical reasons. It wasn't possible to put into the reasonable adjustments, but because the NHS itself didn't have a way for us to pass the IG checks when what we weren't doing was providing a professional system, because this was a personal bit of information coming from a patient. And there was no mechanism within NHS Digital, as it was then, in order to assess us. So it wasn't that they said we were valid or invalid. They had no framework to ask the question, because they were used to dealing with third-party systems that were used by health or social care professionals. So that's just a very quick story to say kind of the sort of macroscopic changes that need to happen in order to get to where we want to get to. And in the meantime, what happens is lots of people like Maldaba come up with brilliant solutions, but then they are just adding to the silo, because there isn't a way to join these things up. And I'm a big fan of joining them up, although I would urge a caution that if that joining up is going to be done by other private companies and not by a centralized public body, it is in itself really risky for the health of the innovation, the creativity that exists in the digital health sector.
Absolutely. I think for the international viewers, we possibly may have systems that we envy in being able to do things in flexible and different ways. I know the NHS can be the envy of other countries as well, and we've got the benefits of some things being done in quite a joined up fashion, but digital remains challenging, probably amongst the most challenging. But there is progress. This Lorenzo has just alluded to the reasonable adjustment digital flag, which is setting a new infrastructure in a way for information to be shared around the reasonable adjustments required under the Equality Act in the UK. for that information to be shared between health and care providers, effectively using what's called the spine of the NHS, a sort of central part of it digitally. I'm keeping in touch with the chat there. I think there's absolutely a lot more we could say about data and the role of digital in this. But somehow we've come to the final 5 minutes, so I think I should probably invite each of you to give a few closing remarks for a minute or so. So Jo Johnson, can I come to you first to give a few closing thoughts?
Yeah, thank you. I think it's been a really good conversation. I think, Lorenzo, as you mentioned about the Hear Me Now and that opportunity, I think that was really powerful, and the impact it made for that individual, that was really powerful. And understanding the journey, I guess, Jo, thank you for going to the library. But actually, I found that really interesting, that history. Thank you very much. I guess in closing, it's something that it's really important, isn't it? It's what we would all want. And for me, I always think that this could be me. This is my family, my neighbours. Personalisation is just something that we should be doing. We shouldn't need. It should be natural for us to do that. But unfortunately, the way that we're working seems to have somehow got in the way. But I think it's the right thing to do, and we need to continue to progress to ensure that we're always putting that person in the middle of everything that we do.
Absolutely. And Jo Spearing, some closing remarks.
Yeah, so what I'm going to do is I'm going to use the closing remarks to introduce a couple of wrinkles, because I'm an economist and we're supposed to do the on the other hand stuff. We still need to think quite seriously about how carers fit into personalisation, particularly when the patient might be unable to make their own decisions. Are we then personalising to fit the needs of the carer or the needs of the patient? To what extent should we think about fitting the needs of the carer versus the patient? I think we need to think about what implications this might have for health inequality when we're talking about people who might be more or less able to make decisions for themselves. Are there some people who aren't going to be able to benefit from personalisation to the same extent of other people? And then we also need to think about quite seriously about heterogeneity in patient preferences. So there is some academic research that looks at different types of patients who might want to have more or less say over their healthcare. So I think we need to think a lot about kind of meta personalization. Do we need to personalize the extent of personalization? None of these things is to say that, you know, the personalization agenda is not something we should be thinking about. What I'm saying is I think we're now at the stage where we need to engage very seriously with the fact that the real world is incredibly messy, and that this is going to throw up a lot of problems that we need to work our way through. I think as we've progressed, that's likely to become more and more the case, and so we need to grapple with that as well.
And Lorenzo, a few words.
Yeah, thanks, Paul. I think personalisation will increase and should increase, and the work we're doing is moving in that direction. There's a question of how fast and how long it will take. I think, as we've said, we need to improve the configuration of the finances, as already described, so refocus them on things like primary and community care to enable these changes to take place. And then what I think we need to do is really focus not on the patients, not on the people receiving care, but on the organisations, the structures and the frontline workers and the teams who are providing it, to change the mindsets in some of the ways that we've discussed in order to enable those changes to take place and change the metrics and measures of what good and what successful looks like, so that they understand and are able to adapt to those changes. Because I don't think it's patients who need to adapt, they're already there. I think it's the health and care structure that needs to catch up with them.
And we've managed to get to the end of the webinar without getting into the thorny topic of AI and how AI might impact on that, the growth of big data. We've got so much information about individuals. I think Amazon and Google and the other big providers, they're personalizing what they deliver continuously to a degree that we might find little intrusive at times. But how much should we learn from them? How much should we keep that at arm's reach? Anyway, in closing, I'll thank the panel. Thank you so much, Joe Johnson, Joe Spearing, Lorenzo, and thanks to Maldaba for hosting and putting this on, essentially. I really look forward to further episodes in the series of webinars. So thank you all, and thank you all for joining.
Thank you very much.
Thank you.